Welcome back, Smile Mentor family. Today's episode is one I even learned some on, even with our experience in the dental industry and talking to all the patients and surgeons we have in the past. At 4 weeks, you are absolutely the most vulnerable when it comes to having your All-On-4, All-On-6 dental implant supported arch procedure done. And you go a little while. I mean, you think you're the most vulnerable on your right when you get the surgery. And ironically, you have that primary stability, the initial stabilization. So I'm not going to ruin the whole episode for you guys. Tune in. I think you guys will enjoy. You're going to hear Dr. Ratana talk about some of the osteoblasts and osteoclasts and words that I still can't spell, but appreciate you guys joining us. I think you guys will really enjoy this. And for all our subscribers out there, thank you. And for everybody who is yet to subscribe, please do. We are a community. We have to get that voice out there, and the bigger the community is, the more power the patients have. So I appreciate you guys, and here we go. Today we're on our 4-week appointment, right?
Yes, sir.
We took our CT scan. Now you had a chance to review it. Do you mind sharing with me what you at least saw in the CT before you look in the mouth? I'm following the rules pretty good. Not 100%, but pretty good.
Not bad.
Well, what would you expect?
Griffin? Okay. So I was looking for the integrity of implants, all of them right after we place it. So I just wanted to see this lovely alignment of bone around all the implants we placed.
Praise God.
Even this one here, I placed some grafting that looks really solid. Implant is all the way in, covered with all the bone from all around, which is beautiful. Bone all over. Even the two implants here, the one behind each other. And the good thing is this also pterygoid one is all the way as it should be, exactly planned by my beloved Megan. Yeah.
So, let me ask you a question.
Mm-hmm.
You've done implants on me before.
Mm-hmm.
We've had problems, right? I mean, we've had some really good ones, and we've had some challenges in the past. I know that I've had some lifestyle changes, not smoking, all those kind of things helps, right? But from what you see for a 4-week integration standpoint, because can you tell if it's integrating much right now? Are we in the osteoclast side, or are we still in the osteoblast, or what?
You can't tell this one.
You can't tell that
yet. You can't tell this. It's
okay.
Too early to say it this way. But you can tell that the implant are in the right position. Everything looks fine. Everything looks great. Nothing looks awkward or something. I mean, I don't expect any reason for why this should fail.
Right.
The one that we have problem with, I know it before it happens. I told you, like, this is not a tooth to be immediately loaded. With immediate extraction, it's not really a good idea to do that. And it happened. But with this one here, with the concept of All-On-4, all of them, it looks to me like we have a good distribution of forces all over. Everything looks perfectly fine to me.
Perfect.
Yeah.
And well, I know you're short on time, so I'll let you peek in there, and
Okay.
we'll ask any questions that you might.
Just need the girls to be here.
Okay. Well, that was a really good report, and I know he's about to go. Dr. Skander's about to, who was he's a surgical prosthodontist that did the surgery part for the All-On-4. Well, in my case, All-On-6. That's good news.
Yep.
We like these appointments.
With those needles.
Right.
Okay, back one. Look at you. See how clean they are. Good job, my friend.
Thank you. Trying hard. That water pick hurts, by the way, first time you use it. If you do it too strong, it's strong.
No, it's you have to go with levels little by little.
I learned that.
Yeah. You should have called Laura Thompson. These are deep.
Now let me ask you a question before we get into this. When I came in after that 24 hour to put these in, that hurt like hell. So will this hurt at all taking this out?
I'm not going to do it at all.
Okay. I was just gonna ask you to numb me up. You know.
First of all, like now our protocol, we don't take them out at all. Once they're put in and screwed in, that's it.
Really?
All what I'm trying to do now is just make sure that all the screws are still tight. That's it.
Okay.
Yeah.
Perfect.
Thumbs up, man.
Perfect.
Looks perfect.
Perfect.
Okay.
Well, thank you. Does Dr. Ratana have somebody right now also?
No, he's, you know him?
Yeah, just because I want to make sure I have all my appointments listed on my Q&A part of it. That I just want to make sure. I mean, you'd think I would know this, but I just want to make sure that I got everything.
Sure enough, man.
Okay.
But I have high expectations this one.
Praise God.
That's good.
That's good.
Yep. Keep.
I'm not gonna. I'll hammer down. That's good.
So I'm gonna put the seal one more time and bring it up to the time.
Thank you, Dr. Scanner.
Okay, you can go ahead and relax.
I forgot to ask Dr. Scander. I'll ask Dr. Ratana when he comes in, but are stitches, am I supposed to still feel stitches? I am? And that's okay?
That's normal. So sometimes stitches will stay in place for up to 8 weeks.
Really?
It just depends, like you can either heal really fast and stitches will start coming out like within 2 weeks, or there's some spots that are, it will take longer for you to heal. So after even, like I said, like 6 to 8 weeks, sometimes you will still feel them.
Yeah.
But they're gonna come out.
Okay.
And if they don't, then you just come here and we will remove them for you.
Okay, I just want to make sure. Cool.
Yes, sir. So let me go get Dr. Ratana.
Thank you, Laura. Come on in, have a seat. You got a minute?
Yes, of course.
Okay. So, okay, I'm trying to make sure that I have all my appointments on this. So I'm going to have an FAQ section. I'm going to have other patient testimonies. I've got all my appointments that I've done with you guys up to this point, and we're going to document the rest. As I go through it, what appointments, you got your first initial consultation. After the consultation, pre-op.
Yes, pre-op.
Once you do pre-op, then it's surgery.
Straight surgery, yeah.
Correct?
Yes, then follow up 1 week later. Yeah.
1 week later, which we did the 24-hour appointment to actually put in the temps.
Yes, exactly.
And now we're here at the 4-week appointment.
Yeah.
To look at how it's integrating.
Just to check everything is good, the bite is good, the temp is not broken, like any exposure or anything, like everything is healing nice.
What do you think? I already got Dr. Scander's impression.
We're looking here is that you have no infection, the implant and all the parts are connected, that everything is stable, So let me check. Nice. Okay, let me show you. For example, this is a socket. You see the socket of the extraction socket? So everything is healing. You see? Okay, and then here you can see the implant. The implant is completely surrounded by bone. So So you go one by one. This is the same one. This is the second one, the same bone all around the implant, no infection. The next one, you see? Bone, all the parts are connected. Then this one, you see? The same, surrounded by bone. This is very important that you have enough bone in the vocal part, at least 2 millimeters, you see?
You want at least 2 millimeters?
Yes.
Okay, why did I think it was 1? You need at least 2.
I mean, imagine that you always have like a remodeling and all that, but the thickness of the tissue, of the bone tissue I'm talking about around the implant should be at least 2 millimeters to be stable.
Okay.
Yeah. This is the other implant, and this is the the pterygoid implant, you see? Perfect.
I mean, that's something that I know clinicians know what you guys have a good understanding that you have to give patients bad news sometimes, and sometimes you get to give them good news. But patients that have been to this All-On-4 process, or to this point, right, that now they're here and they're, they've had so many failures in their past and infections. I'm talking about me, and so now to come in and hear an appointment that
everything is good.
That everything is good. I mean, really is a big deal and good
because
news.
you can see it, so you can see that there's no infection. You have all the implants surrounded by bone. So at this point, everything looks good. Of course, we try to avoid complications. Of course, that's why we try to be like 2 steps ahead of everything. But we may have complications. You may have an infection. You may have an implant that is not osseointegrated, for example, and we just need to deal with it. Okay, we just need to do what we need to do to fix it. But basically, it's not very common if you know the pathway. If you know the pathway to get to the good spot, everything is good. Nothing to worry about, man.
Awesome. Okay, so now we've done our 4-week appointment. What are the next appointments coming up?
Okay, then we need to check at the 4th month, like 3 or 4 months late after the surgery. We need to check the osseointegration of the implants clinically. Okay, we take x-rays again. We remove your prosthesis because at that point we're able to touch everything. It's supposed it should be. If an implant is not osseointegrated at that point, it's not going to osseointegrate. You may have less bone around the implant sometimes, and we, depending on the patient, we wait a little bit longer. Okay, but usually at that point should be everything osseointegrated. So we just remove the denture, we check the implants, we check the soft tissue, everything is healthy. We proceed to make a final impression. Okay, final impression. Why? Because we already have an impression where we did your temps, but we do a final impression with the position of the soft tissue, where it is, everything is already healed, contours, everything. Okay, so at that point we do final impression records, and depending on this step, for example, imagine that you say, no, I don't like this front teeth. So we do the changes that we need, and we proceed with another PMMA. Okay? So we do what we call...
That's if there's something after the 4 months that I keep looking in the mirror and I'm like,
Exactly.
I don't like that. You're going, all right, we've gotten all the clinical pieces out of the way. Now we're going to the aesthetic side of things, and we're going to make you another temp based on our conversation, which will then... That would be that point where you would put a new PMMA.
We call it the trial PMMA. Okay? That actually we do it with 99% of the patients. Why? Because sometimes we don't load all the implants. Sometimes we load only the 4 anterior implants, for example. So everything looks great, but we need to do the trial PMMA to the final contour of the final prosthesis, so we'll get to the last implants. Okay? For example. Okay.
Because you guys didn't load, that's why.
Sometimes we don't load the most posterior implant, or maybe one of the implants you did a lot of grafting, so we keep that implant without any loading during the healing process. So yes, we need the trial PMMA. Okay. So in your case, we load all of them. So in your case, it's maybe easier because if you like this, we just proceed to the final. Okay. If we need to do changes, we do the trial PMMA, and you try it for a couple of weeks.
Okay.
to see if you're not biting your cheeks, to see if your speech is good, everything is good. Maybe you say, no, I don't like the gum shape, or I don't like the incisal edge of these, whatever, okay? So we do those changes in the PMMA before we go to the finals. Once you accept that one, everything is good, you try it, your family approve it, we just move to the final one. Okay. Because once we do the final, we cannot do any changes. Okay, so it's a very expensive change. We move forward.
That's right.
Because, I mean, imagine. Okay?
Yeah.
So basically that.
Let's see here. I know there was one more question I wanted to ask you. I already talked to Laura about feeling some stitches. She said that's normal.
Yes.
I've got on the front, I'll feel it, and I just want to make sure it's cool, that they didn't dissolve or go away. Yeah. Is there anything, we had talked about this technology I'm trying to use for the healing and the pain management process that we've talked about. My hope was, or my thesis was, in using this during this process, that I would, be able to not use any pain medicine, which I was able to do. I mean, I used some CBD oil and that was it. Never any narcotics.
That's perfect.
I know. So secondly, the healing process and that type of stuff, it seems to be at least healing well from what you're seeing.
Perfect. Yeah.
And so, but then the third part was the integration, the osseointegration. You're saying at 4 months I come back and do that. What could be the earliest we could test that out and really feel comfortable or know? Because I would like to know if they're integrating faster than normal, because we've got some of my past history to kind of check.
I used to load all the implants at 8 weeks. I'm talking about 10 years ago or 12 years ago. Okay, I used to load the implants 8 weeks, always, okay? Because 8 weeks is okay. I mean, you're almost there, okay? But in some cases, you won't have like a high percentage of bone around the implant, and you may break that connection because it's not completely mature, okay? So some cases, you start working at that point, and because you have, imagine that you have 31% of bone implant contact instead of 60. So yes, it's good, it's healed, and there's no infection, but it's not strong enough
to withstand the torque.
Exactly. So maybe you target spinning implant. So at that point, there's no infection, nothing. We wait again, the healing process. But you broke those little connections because it was a little bit early. So we prefer to wait at least 3 months. Okay. Some cases we do extra procedures like grafting, huge extractions, this and that. So in those cases, sinus lifting, for example, we wait 4 months. Okay, but 3 months is a good number.
Okay, so but there's no way to know if it's osseointegrated unless you take the prosthesis out. Is that correct?
I mean, we can have, to check if the implant is osseointegrated, you need 3 things, okay? Clinical evaluation. I mean, you may use clinical evaluation, radiological evaluation, and then we test it. For example, we have some devices that they measured. It's like a frequency analysis, resonance frequency analysis of the implant. So we don't need to torque it, we just measure this magnetism thing, so we measure and we have a number of the stability of the implant. So we have an idea of that. So we use clinically, yes, we check clinically, we see the soft tissue, we probe, we do whatever we need to do to see if everything is healing, there's no infection, x-rays, and sometimes we use this, what we call this Ostel, is an ISQ measurement,
Okay.
Implant stability quotient, that's the name. So with that is how we measure if the implant is osseointegrated.
So let me simplify this. How would is there any way I could test or see the progress of the osseointegration without jeopardizing the healing or the integration process, to see if that technology does speed up or help out the integration process? And I know we talked about this, you got to have a big sampling. I'm doing this primarily for me.
I know. Yeah. I mean, the only way to do it without jeopardize anything is using the Ostel, this type of device, because you're measuring without touching the implant that much. You just screw retain with your hand this tip, and then you make like a magnetism thing. It's like the analysis is just you need to approach the tip of this probe to the implant, and you have a number. So that's how we measure. Actually, that's the way to measure with these machines, that you need to have several measurements just to see the difference between them. Okay, so in some research projects, what we do is that we place the implant, we measure implant the day of the implant placement, 1 week, 10 weeks, 6 weeks, and that's how they measure, and we measure the osseointegration of the implant with numbers. Yeah.
And you have to take the prosthesis off, and then that's where you get to the implant itself, and you are then using and testing that out.
In your case, because your implants are loaded, that's the risk. That taking out and placing again.
It's anything you take on, off, you can
move the implant.
That's right.
That remember, we need to have less than 15 microns of movement on the implants to have a nice healing. So of course, if you touch those implants during the healing process, there's a little risk.
And that was one of the things that, as I grew in my knowledge in this, we went to a consultation with Clear Choice, and they were talking about how they did every year. They'll take the prosthesis out and clean it, and how expensive it really was. And in my learning process, you don't want to keep taking it in and out, because the screw integrity and everything, the integrity, you don't want to do that more than you have to. Is that a good way to put it?
Okay, that will depend on two things. One, if you're working tissue level, or if you're working implant level. If you're working tissue level, you can remove the prosthesis as many times as you want. But if you're working implant level, every time you remove the prosthesis, you're going to detach that tissue sealing around the implant, maintaining this sealing to keep it healthy, biologically speaking, okay? So we don't remove implants and parts and crowns every year, okay? We try to keep it that way because you need to maintain that tissue that is attached to your prosthetic part. If you're working tissue level, that means that you have an abutment, like in your case, you see? You have these abutments that we call multi-unit abutments. You can physically remove the prosthesis as many times as you want, that you're not going to jeopardize anything. But you need to change the screws every time you do it. Okay? The screws connecting the prosthesis with the abutments. So that is...
So you're saying there's two ways to remove... So walk me through this. This is the first time I've ever had this conversation. So you can remove the arch, the prosthesis, on a tissue level, not an implant level. So it comes out and nothing is affected on the tissue side of things.
Exactly, on the tissue surrounding the implant, yeah.
But then there's another way to do it where you actually have to remove the soft tissue around.
No, not remove the soft tissue. Is that when you remove the prosthesis, the start point of the prosthesis is going to be the implant level, that is at the bone level. So you have this tissue part that you detach from the prosthetic part, okay? So we don't have a sample here, but let me see. The implant is bone level. On top of that, you have soft tissue, okay? So in your case, you have abutments. Imagine these are the abutments. These are removed. This is for a removed prosthetic. So these are what we call locator attachments, okay? But imagine these are the multi-unit attachments that you have. So you have like an inner thread here where you're going to screw retain the prosthesis. If you remove this part several times, you need to the soft tissue surrounding that part is attached and is sealing against bacteria going through the tissue to the implant and all that, okay? So imagine these are your multi-unit abutments. Every time we remove your prosthesis and all that, who cares? You're not removing the sealing around the implant.
Okay, hold on, let's see. It's funny, I was just doing this. Okay, so now...
Okay, you have it here.
Right? This is a good way. This is your multi-unit abutment, right?
No, this is not a multi-unit. This is a simple screw retain abutment,
okay.
You know? But imagine this is the implant. The implant is bone level, okay? On top of that, imagine you are placing the implant, so you have a flap. So imagine you place this one. Imagine this is the multi-unit abutment. You place it there, and you close the soft tissue. The soft tissue is going to heal around this section, okay?
Okay.
So now the tissue is going to be there, okay? Not here. The implants are not exposed to the oral cavity. The abutment is exposed to the oral cavity, okay? So if you have now the prosthetic on top of this multi-unit abutment, you remove the prosthetic, but you're not breaking that ceiling, you know?
Because you've not gotten into it's sealed around with the tissue in this case, and you can take it on and off because you're not touching with it. Okay.
But imagine that the prosthesis is going straight to the implant platform, okay? So once it's healed, the implant is there, you see?
Mm-hmm.
You have like 3 millimeters of tissue, okay? So the implant is there. So every time you remove, imagine that everything is connected, you know, like the multi-unit and the prosthesis is one piece. So you understand it that way. So every time you put this and remove this, you break this attachment. So this is going to heal like that, and then there's no sealing. It's not sealed around the implant. So you have this connection between the oral cavity and bacteria going inside of the bone and the implant, and then you start having bone loss, bone of the marginal bone. Yeah.
So a multi-unit abutment. What's the difference between this abutment and a multi-unit abutment? Why? I don't know this after all the things I've heard. I just never.
Okay, multi-unit abutments are the ones that are used to restore multiple units. Okay, so for example, this abutment
will restore one crown.
Yes.
Right, and so then the other one will restore.
So imagine you have these implants. You see the different angulations of the implants. How do you get into that connection with this positive part, male part, to engage to the connections? Is impossible, because if you have this divergent position, you cannot get there. So the multi-unit abutment is going to be a very low profile abutment, because this is not a multi-unit, you know, it's different. So the prosthetics will be, instead of having a male portion going to the implant, you have a female portion going to a very shallow, short abutment. So you have no interference with the connections, nothing. You're working on top of those. So it's like a very conical, you know?
I've heard the conical. I mean, I've heard that term.
Yeah, this is conical, you see? So this portion, you see, it's easy. You may have differences between the angulations, but you can see this. But if you have this, imagine this. You have this like this. 6. How do you engage? You cannot get in.
Right.
If you have a 10 degrees.
Because so look at how far off that is versus that.
Yes,
you're talking
so you cannot get in.
Serious.
Imagine you have to get into the connection. Male. Imagine male going into a female. Okay, male is impossible. Okay. But if you have everything flat against flat, this is almost flat, you can have the divergence and it's good. That's why we call multi-units, because you can restore multiple implants together without any issue of that angulation.
Thank you for finally explaining that to me. I mean, that I've heard it used, and with all my stuff with MIS and all that, I've heard these talked about, and I'm going, what's the difference between a stock abutment? I know there's custom, I know there's stock, and then there's multi-unit. And I'm like, okay, I get the custom, I get the stock. What's multi-unit? And now I know.
Yes, the multi-unit, you're converting the female connection into a male connection.
Best way to put it.
So now you work with a prosthetic as a female, so it's easier. You know, there's no huge connection, it's just a very shallow connection. So instead of being 7 millimeters going inside the implant or whatever, you know, it's just a couple of millimeters and easy to see it because it's almost flat against flat.
Perfect. Anything else I should... Okay, let me ask you this. I mean, I know... Once I have a good... Are you busy?
No. I have an appointment at 3, but that's...
At 3?
Yeah.
Okay, I'll hustle. Do you see any danger here that I have eaten anything too hard or anything like that would cause any concern?
No, I mean, I'm not able to see anything there, but you need to know, and you already know, that this is like this is where you have the last anchorage of your implants at this point, you know? Remember, the deep zone, okay? Because the initial bone creating the mechanical retention is not there anymore. We already removed that bone because we injured that bone when we drill and we did all and we placed the implants under pressure, so that bone is gone. but you're healing. So you're creating new bone. But the new bone that is going to create the secondary stability of your implants, okay, is not there yet. So
because we're at 4 weeks, and really 8 weeks is when you feel more comfortable on that, right?
Yes. So at this point, everybody says, "Oh no, the surgery was 4 weeks ago. I'm good."
This is the most dangerous.
Exactly. If you get too confident biting things, you may. I mean, it's dangerous for the implants.
So, and I appreciate that, because you do. Just letting patients know out there, please don't let yourself, because I can speak that all of a sudden you kind of, check in. Yeah, I can do it. And so be careful on how.
Because you don't have pain right now, you know?
I don't.
The first week is the safest week. You have pain and you're like self-conscious, you know? And you're like, no, I'm not able to bite. But suddenly you have 4 weeks without pain. And then you say, let's do it. And so you start eating. If you're working with multiple implants, all of them, they are connected and it's safer, you know, because they are holding it between them and everything is connected. So you have better prognosis in that sense. But if you're working with a single implant, for example, sometimes we do loading of one implant. That's very dangerous because you're going to move that implant everywhere.
Yeah, which is what I did. I talked Dr. Skinner into doing that, and it failed. He did not want to do it, and I said, please, because it was one of my front ones, and I couldn't. It failed. Okay, and then so you would say the most dangerous window for the All-On-4, All-On-X, is probably 3 to 5 weeks?
Yes.
Is the most dangerous window. Once you get past week 8, really is where you should, then maybe, but still keep it plastic
week
fork.
8 you're good. Yeah, I mean the issue is that you may have other type of complications like breaking the tent. Okay.
Right.
So I mean that's very easy to fix.
Right.
But
still,
if you break it and your implants are in the danger zone, so that's not good because supposedly you cannot touch the implants. And to fix it, you need to touch the implants. Okay. So to make it simple, 10 weeks without touching 10 weeks without doing anything crazy. Those teeth, very soft food, and I always say as a joke, those teeth are just to read.
Just to read.
You know?
It's a good joke. I like it.
Is it?
Okay, because you do. I mean, I all of a sudden I'm kind of like I feel a little more confident, but I never understood the primary stabilization and the osteoblast and osteoclast part of it, and that's when I went home. And the good news is with that technology, I was able to be out of pain pretty quick. I mean, I really after that appointment that day kicked my high knee, but that first 24 hour. But after that, I mean, it was really quick And I thought, okay, so the hypothesis is I would be safer now to eat something a little harder, which I shouldn't. I'm not recommending for people to do that, but I'm safer to do it now than I am 4 weeks from now because of what I just learned, and that's correct.
Exactly. Now means at the beginning of the healing process, the day of the surgery, but not now because right now you are the
exactly.
Yeah. I mean, if you meant now when they place the implants, yes.
Yeah.
But now you are in the
most critical stage.
Yeah.
So I really should be extra cautious now.
Yes.
Okay. I'm gonna,
just soft food.
And you know, the amount of money I spend on this or anybody's going to spend on it, you can suck it up.
And at this point, that's your job, you know, because we cannot take care of you during the daily basis, you know. So you need to be careful with your teeth, with what you eat, you know. Some people, and that's part of learning with patients, you know, because you learn a lot the personality of the patient. And are you seriously? Some cases you have everything perfect. But the type of patient is not aware of what we're doing, so you prefer not to load the implant, for example. Okay?
Really?
Yes. Everything is good, stable, beautiful. But the personality of the patient, that he's not aware of what we're doing, he doesn't care, he's going to bite whatever. So in those cases, we prefer, for example, it's a very low percentage, of course, but you need to understand that, and you say, no, this case is not to load the implants.
I'm surprised Dr. Scanner didn't put me in that category. if he's told you anything about the kind of patient I am, then...
No, but you understand what you're doing. So of course you're going to take care of it. But seriously, some patients, they just, teeth, they don't even know the difference between implants and this and that. So it's, I'm going to have new teeth and that's it.
Yeah.
And you say, don't eat anything hard. Next day, they're eating everything.
Mm-hmm.
So you need to read that, in between lines of the patient that...
So you just put a denture in that case?
Yes.
Okay. That comes in and out?
Yes.
Okay.
Yes.
I'm glad you guys didn't do that with me. Thank you.
And sometimes we're doing that for, imagine, single implants. More dangerous, okay? So the patient has one implant, and instead of loading that implant, we just put a temporary, holding with the neighbor teeth. And if he breaks that temp, means that he was going to damage the implant. So sometimes the patient is like, I broke this temp, so this temp is not that good. Maybe it was better to load it.
No.
That means that if we load it, we go straight to the implant. Yeah. For example, so we need to also evaluate that part. That's part of the patient selection criteria that you need to have for these cases, yeah.
Well, we're going to have a lot more time on camera. I don't want to make you late for your last patient. I appreciate you coming in to share with me some of this. I mean, that actually helped me you think about how many years I've been doing this, and now I'm learning some stuff. And especially once you go through it, you pay a little different attention to some of the terminology, like multi-unit versus stock and versus custom. So, well, awesome. Well, I really I appreciate it. Is there anything else I should be thinking about, or
any weird sensation? Let us know. Like you start feeling pain or whatever. You need to let us know. But basically, that's it. Take care, soft food, and clean.
Okay. The good news is he looked at it and said, extremely clean and good and healthy gums, and I'm going to keep treating it with this technology, and I would love to. So last question. I know I've said that probably 3 times now, but last question: is there a way, maybe in 4 weeks from now, which would put me at 8 weeks, to test with that machine? Do you guys have the testing machine?
Yes. I mean, I don't know if it's worth it to do it, but yes, we can do it. Yes. We can test it. We can.
I know. I'm sitting here thinking, God, if you're nervous about it, I don't want to push it, but I really feel so confident about this that if there's a way to kind of go, this is doing some osseointegration, that because I have some history with Dr. Scanner, and because he's seen how long certain things take to osseointegrate for me personally as a patient, and that type of stuff, I feel like it kind of gives some benchmarks a little bit for, nothing to produce in Harvard papers yet, but still something to kind of go, But I also don't want to jeopardize anything.
Yeah,
so
I recommend wait 3 months, and we do that 3 months, man.
3?
Yeah.
3 months it is.
Yeah.
How about we do that? Okay. Okay.
Instead of 4 months, let's do 3 months, but not 2 months,
Fair enough.
Okay?
Okay. Appreciate. Oh, yeah, we'll do that. Okay. Thank you.
Thank you, man.
I really appreciate it.